This is Dr. Howard Strassler with the Hints from Howard on a prosthodontic procedure. Today we'll talk about simplified temporary restorations using dimensionally stable Bis-Acryl composite resins. When you look at temporary provisional fixed restorations, they have some basic principles. They certainly protect the underlying tooth structure and preparation, but they have additional purposes. After preparation, they aid in the healing of the soft tissues that have been traumatized during preparation and impression. They help determine adequate clearance and tooth reduction. After fabrication, you can measure them for thicknesses in different critical areas. For anterior teeth, they provide an aesthetic trial for color, contour, length, width, and shape, and for the patient to evaluate whether or not they're happy with the aesthetic result. And they maintain occlusal and proximal relationships to stop the tooth preparation from drifting. That would cause the teeth to move, and when they move, the final restoration that's fabricated by your laboratory won't fit as well and will need additional adjustments. In the past, the only choice we had was a powder liquid methyl methacrylate. It was difficult to manipulate it. It had poor physical properties, excessive shrinkage on polymerization. It generated heat during polymerization, but most importantly, had an unpleasing odor, and it was radiolucent. One of the comments we'd usually make is they shrink and they stink. The introduction of methyl methacrylate was overcome with auto-mixing composite Bis-Acryl composites. They have minimal shrinkage during polymerization, no odor. Some are even dual cured, so they light cure for quick setting. They're filled with glass fillers by 35% weight. This improves the handling and increases wear resistance. They're radiopaque, and in fact they're very polishable, although many times I'll glaze them over with an adhesive resin and light cure them to smooth the surface. So Bis-Acryl has advantages. More resistant to occlusal wear. They'll be longer lasting if necessary. They're rapid setting, so we can remove them from the mouth in less than 90 seconds, although understand the manufacturer's instructions and the timings they recommend. It's quick and easy to use. It's easily repairable with a flowable composite. There's minimal shrinkage during polymerization. Minimal heat generation, so the pulp will be healthier. Radiopaque. Most are self-cure, so no lights required, but you can find those in the market that are light-cured, so that if you wanted to do a snap set of the material when you remove it from the mouth, you can. They have excellent color stability and they're stain resistant. You can trim them easily with burrs, diamonds, and discs. I prefer discs, and I'll show you how I use discs later in this presentation. And once again, they're highly polishable and smooth. They pass the patient's tongue test. And we've got many choices. From LuxaTemp to Integrity, Access Crown, TurboTemp 2. Lots of different products are out there in the marketplace. They all work in a very similar manner. They're all auto-mix. They come in specialized cartridges, either hand dispensed through a handheld syringe, or you might have to use an impression gun applicator in order to dispense them out. In many cases, the applicators are different for different products. Know your product, have the right tools. In fact, even the auto-mixing tip are specific for the product to make sure you have an accurate mix of base and catalyst. So let's take a look at a case. This patient presented with a history of pain on chewing of this mandibular molar. Diagnostic testing with a tooth sleuth, and we found that there was a cracked distolingual cusp. The amalgam was recently placed, no need to redo the foundation, and we decided to do a treatment plan of a PFM crown, although today we might even also place an all-ceramic crown. Before beginning the tooth preparation, we need to fabricate a carrier. So to fabricate the temporary crown, we're going to use a self-mixing medium-bodied, fast-setting vinyl polysiloxane in a bite impression tray that has sides to them. We can use a disposable quadrant tray, and the reason I use this and not a putty is that the walls of the tray stop the material that when we seat it from actually moving out. The walls give you a much more accurate temporary. For some people will go in and use a fast setting bite registration material instead of a PVS material. Some extra hints before you make the template. Certainly check the occlusion. If the tooth is shifted, you may want to use some old composite you have in the drawer that you're not using to restore teeth, but you won't throw them away because it's too expensive. You can put it and build up the composite to full form, have the patient bite down on some saran wrap, and then light cure. This avoids a thin temporary in that area where the tooth is shifted. You can also use that composite to reestablish the tooth position by adding composite in the facial lingual. Once again, you're trying to avoid thin provisional material. And if the cusp is fractured when the patient comes in and you're not rebuilding the cusp with a new foundation, you can add the composite to build full tooth contour, light cure it, and then make your bite registration, make your impression with your bite tray. So before the crown preparation, you're going to take that bite impression tray or a disposable quadrant tray, medium-bodied fast-set polysiloxane material, or a bite registration material. You'll seat it in the mouth. You'll make sure the patient bites down, and you'll have an imprint of an unprepared tooth. That's going to be critical in your fabrication. Make sure the patient's biting in maximum cuspation when you put this tray in. You can hold the tray up to the light, and if you see some light coming through where the occlusion's been established, you know that the patient is in maximum intercuspation. After the tooth preparation, put the carrier back in, reseat it, verify insertion and fit. In fact, have the patient practice biting down. Crown preparation is cleaned and dried. You're ready now to place your Bis-Acryl resin in the tooth imprint. In fact, syringe the Bis-Acryl with the auto mixing tip right into the imprint. You're using a dual cartridge auto mix tip to assure yourself of complete mixing of the base and catalyst pastes. Make sure you fill it from the inside out. Make sure you go past the margins. Reinsert it in the mouth, have the patient bite down and verify the relationship. And now the clock is ticking. Typically, you're going to keep the bite tray in the mouth between 75 and 90 seconds. Know the timing for the product you're using. When the time is up, have the patient open up, and I find that usually the temporary crown comes out with the impression material, with your registration, with your imprint. If it doesn't, immediately remove it using a scaler. Don't let it sit on the tooth. Sometimes it doesn't come off because it's locking into the interproximal of the adjacent teeth, the fact that you've lost some of the gingival papilla, and there's a more heightened proximal surface and contour. You then put it aside on a countertop and let it fully set. Usually it sets 4 to 5 minutes. If you're using a light cure, dual cure variety, you can hit it with the light for 20 to 40 seconds and get an immediate setting. When it's set, you can then take the temporary crown, you can remove it from the carrier if it didn't come out, and now you're ready to trim. And for me, I like using a coarse Softflex disc. It's an easy way to simplify removal of the excess resin. In fact, if you look at this picture, I'm using it around the marginal areas. I'm removing all excess flash. It gives you nice clean margins. You're looking at the crown, trimming it from the inside. You're looking at the inside and looking at the marginal areas. Yeah, I think if you try this technique, I think you're going to like it a great deal. Once I've tried it back in, and in most cases with an accurate bite impression carrier, there's no need for adjustment of the proximal contacts and occlusion. I've tried it in, I polish it. Typically I use an enhanced polisher or any of the silicone or rubberized composite polishers, or you can cover it with an adhesive resin, air thin it, light cure it. It's nice and smooth. Now I'm ready to cement it. When I'm cementing it, and you may already do this, I use either a small amount of Vaseline on a disposable brush or a water-soluble lubricant only in the cervical third of the outside of the crown. It makes cleanup of the temporary cement a lot easier. So then I'm going to apply my provisional cement. Now, even though many provisional cements come with auto mixing tip, I don't use the tips. The tips cost about $1, as well as it leaves a substantial amount of cement inside the mixing tip. What I find is better is I syringe a small amount onto a pad. I use a spatula and mix it together. I then pick it up with a disposable brush and I really paint a very minimal amount of cement into the crown. I want to make sure I cover the margins. Remember, this is extremely well adapted. You don't need a lot of cement. I then go in and seat it in the mouth. I seat it with my fingers. I have the patient bite down, tooth-to-tooth contact. The temporary cement typically sets within 60 to 90 seconds. I wait till the cement is totally set. I'm using a non-eugenol based cement. Once the temporary cement is set, I clean it up from around the tooth. I typically go in with a scaler. I don't use an explorer. In fact, when you wait till the cement is set completely, it'll clean up without streaking. For the interproximal cement, I'm going in with a piece of dental floss that I've tied into several knots. I floss between the temporary crown, pull it out, the knot pulls out the excess. Without those knots, the floss is just going to go between the cement and the temporary crown. It won't remove that excess cement. Leaving the excess cement will lead to gingival inflammation. You'll get bleeding when it comes time to cement the final restoration. And so my final crown duplicates the contours and anatomy of the original tooth before it was prepared for the crown. It means that when I make foundations, I make them with the occlusal anatomy that I desire, with the occlusion and the shape, and the fact I build it to full shape, so that my temporary will have enough thickness that it will be long lasting. So using Bis-Acryl for your provisional crown and bridge material, you can reduce chair time by almost 30 minutes over the use of a self-cure methyl methacrylate resin or ethyl methacrylate resin. The result will be a high quality, well adapted polished temporary that's more resistant to wear than conventional acrylic resins. It looks good, it fits good, it feels good to the patient's tongue. This is Dr. Howard Strassler talking to you about simplified temporary restorations using dimensionally stable Bis-Acryl composite resins.